Our today's topic of lecture is open globe penetrating injuries and sympathetic ophthalmitis. Penetrating injuries, they are caused by sharp instruments or on foreign bodies which are potentially serious and they could be treated as emergencies. The patient should immediately have an eye shield applied and should be thoroughly examined under general anesthesia. Evaluation of patient for repair should be done at the same time. The gravity of injury is due to immediate damage to the eye, post-traumatic iridocyclitis, which is a common sequelae of perforating wounds, introduction of infection, and sympathetic ophthalmitis. Sympathetic ophthalmitis is the most dreaded complication of perforating wounds. Wounds of the conjunctiva. Wounds of the conjunctiva are common and should be sutured with absorbable 80 or 60 vicryl. Wounds of the cornea and sclera. They may be linear or lacerated. The margins swell up soon after the accident, become cloudy due to accumulation of fluid, thus facilitating closure of the wound and restoration of the anterior chamber. If small and limited to the center, corneal wound heals well unless they become infected, in which case treatment is like that of a perforating ulcer. If the wound is large, an adhesion of iris or its prolapse is almost certain to occur. If small recent injuries, the prolapsed iris should be replaced with the help of intraocular myocol or pilocarpine and the wound repaired with 10-0 nylon sutures. If the iris appears non-viable, it must be abscised and edges of the wound sutures directly, replacing fixed anatomical landmarks such as limbus into continuity first and then suturing anteriorly and posteriorly as required. Scleral wounds more than 3 to 4 mm posterior to the limbus are sutured completely after a thorough exploration. They are also treated with surrounding cryoapplication to cause chorioretinal adhesions and prevent future retinal detachments. Occasionally, in a corneal wound caused by dirty implement or vegetable matter, pyogenic organisms are carried into the eye. They multiply there and cause rapid necrosis of the entire cornea. In these cases, a ring of deep infiltration appears 2 to 3 mm internal to and concentric with the corneoscleral margin. This is also called as the ring abscess. If the organism is Pseudomonas aeruginosa, an anaerobic gram-negative rod, there is extensive chemosis of the conjunctiva, sometimes with a greenish discharge. Enzymes released by the organisms cause liquefaction of the cornea. Usually, panophthalmitis sets in and the whole of the central part of the cornea is cast off. The institution of intensive treatment and appropriate local and systemic antibiotics and a therapeutic keratoplasty may occasionally save such eyes. Wounds of the lens. Such wounds cause traumatic cataract and are always a serious complication. If the wound in the capsule is small, the entry of the aqueous causes localized cloudiness in its vicinity and, irrespective of the site of the wound, opacities in the form of feathery lines appear in the posterior cortex, which later develop into rosette-shaped cataract resembling that of early concussion cataract. Occasionally, the wound in the capsule becomes sealed, particularly if a posterior synechia develops, in which case these changes may be stationary. The integrity of the posterior lens capsule must be assessed preoperatively so that appropriate surgery is planned. If the lens is damaged, it rapidly opacifies. Flocculent gray masses protrude through the opening in the capsule, sometimes filling the whole chamber. Complications: traumatic iridocyclitis, secondary glaucoma. It occurs due to swelling of the lens, which keeps the lens in contact with the iris. Treatment of traumatic cataract in association with penetrating injury, especially if complicated by vitreous losses. Removal of the cataract, performing an adequate vitrectomy, suturing the globe as a primary procedure, insertion of an intraocular lens in suitable cases. To ensure control of infection and inflammation, intraocular and topical antibiotics and steroids should be given. Tetanus is a rare complication. If this infection is introduced into the eye, localized cephalic type of tetanus often results. If the patient is not already immunized, prophylactic treatment should be instituted. Risk factors for poor visual return are a double penetrating or perforating injury, dense vitreous hemorrhage, and blunt trauma. Open open globe penetrating wounds with retention of foreign bodies. The mechanical effects. The foreign body may enter the eye either through the cornea or sclera. Having penetrated the cornea, it may be retained in the interior chamber where it may fall to the bottom and, if very small, lie deeply in the angle. The foreign body may pass into or through the lens by the way of either iris or pupil. A hole in the iris is of great diagnostic significance since it rarely occurs except as a result of perforation by a foreign body. The foreign body may be retained in the vitreous to which it may obtain access by the various routes through the cornea, iris and lens, through the cornea, pupil and lens, through the cornea, iris and zonules, or directly through the sclera. Occasionally, it pierces the coats of the eye and comes to rest in the orbital tissues, a condition known as double perforation of the eye. Apart from its chemical nature, the lodgement of a foreign body in the posterior segment frequently leads to degenerative changes. These may entail a widespread degeneration, but most frequently fine pigmentary disturbances at the macula, often the result of concussion, diminish or destroy the central vision. The vitreous usually turns fluid. Bands of fibrous tissue may traverse it along the path of the foreign body. Hemorrhages may be extensive and retinal detachment may follow. Infection, owing to the heat generated partly on their emission and partly by their rapid transit through the air. Small flying metallic particles are frequently sterile. Infections are most likely to follow the introduction of pieces of stone or wood. Such eyes should be treated with antibiotic prophylactically as in penetrating wounds. Despite treatment, the prognosis in terms of vision is seldom good. Reaction of the ocular tissues to a foreign body. It varies with the chemical nature of the foreign body. Non-organic materials. These materials can be inert, excite a local irritative response that leads to the formation of fibrous tissue, often resulting in encapsulation, produces a suppurative reaction, or causes specific degenerative efforts. Although inert material causes little or no reaction at the time, iridocyclitis may eventually develop. Glass, plastic, porcelain, metals like gold, silver, platinum, and titanium are inert. Lead, aluminium, nickel, mercury, zinc excite local reactions. Iron and copper, the most common materials found, undergo electrolytic dissociation and are widely deposited throughout the eye, causing an important degenerative change. Iron. This causes siderosis. The earliest clinical manifestation is the deposition of iron in the anterior capsular cells of the lens, where oval patches of rusty deposits are arranged in ring corresponding with the edge of the dilated pupil. This appearance is pathognomic and leads eventually to the development of cataract. The iris is also characteristically stained, first greenish and later reddish brown. This is known as heterochromia iridis. As the condition progresses, the B wave diminishes and in advanced cases the electroretinogram is flat. Secondary glaucoma of chronic type is a late common complication and unless the foreign body becomes encapsulated or is removed in time, optic atrophy develops and most of these eyes go blind. Copper. The reaction of copper or brass as from percussion cap varies with the content of the pure copper. If, however, the metal is heavily alloyed, a milder reaction ensues that is called as chalcosis. The typical sites for deposition are in the deeper parts of the cornea at the level of Descemet's membrane, where it accumulates mostly at the periphery, causing the appearance of golden brown ring, which resembles the Kayser-Fleischer ring seen in Wilson's disease. Deposition under the capsule of the lens forms a brilliant golden green sheen, aggregated in radiating formation like the petals of a flower, known as sunflower cataract. Organic materials. Organic materials tends to produce a proliferative reaction characterized by formation of granulation tissue. Vegetable matter such as leaves, fronds and thorns may introduce a fungal infection into the eye. Wood and other vegetable matter produce a proliferative reaction characterized by formation of giant cells. Eyelashes may be carried into the interior chamber in perforating wounds of the cornea. The proliferation of the epithelium of the root of the hair frequently leads to formation of intraocular cyst. Caterpillar hair may penetrate the eye, exciting a severe iridocyclitis characterized by formation of granulomatous nodules, that is ophthalmia nodosa. Diagnosis: the entire segment of the eye must be thoroughly explored with the slit lamp and the angle of the anterior chamber with conioscopy. A hole in the iris or an opaque tract through the lens is pathognomic. If the media are clear, the entire fundus must be similarly searched under full mydriasis. Radiography: indispensable for the discovery and location of the foreign bodies which are radio opaque. Caldwell and lateral views are commonly employed. Computerized axial tomography (CAT) scans the extent of the bony, soft tissue and intracranial injuries must be assessed. Magnetic resonance imaging (MRI) scans contraindicated in case of magnetic or magnetizable foreign bodies, useful in detecting a wooden foreign body and vascular changes. Ultrasonography allows the detection of most foreign bodies as well as associated intraocular conditions such as retinal detachment, suprachoroidal hemorrhage, and a perforating injury of the eye. Treatment: a foreign body should be removed unless it is inert and probably sterile. Little damage has been done to the vision. The process of removal will almost inevitably destroy the sight. Magnetizable foreign bodies are more easily removed by using a magnet. Intraocular foreign bodies are often lightly magnetizable and always small. Intravitreal magnets, which can be readily manipulated by hands, are employed for their removal. If the foreign body lies within the lens, it is better to treat such particles as if they are non-magnetic or remove the lens as a whole. If a non-magnetizable foreign body lies on the retina and if accurate localization has been attained, it may be removed directly by intravitreal forceps as a part of vitreoretinal procedures, which include a complete vitrectomy. Laser photocoagulation of the surrounding retina should be performed to prevent late retinal detachment. Sympathetic ophthalmitis. This is a condition in which serious inflammation attacks the healthy eye after injury, including intraocular surgery to the other eye. Sympathetic ophthalmitis or ophthalmia almost always results from a penetrating wound occurring in 0.2% to 0.5% of such cases. Children are particularly susceptible, but it occurs at any age. It usually begins 4 to 8 weeks after the injury to the first eye. The exciting eye has taken place, rarely earlier. Etiology. The etiology of this condition is unknown, but is considered to be an autoimmune T cell mediated disease. Uveal pigments can act as an allergen, and those who suffer from sympathetic diseases show a skin sensitivity to it. Pathology. Histopathologically, the microscopic features in both the exciting and the sympathizing eye are the same. The pigment epithelium of the iris and the ciliary body proliferates to form nodular aggregation, Dallin-Fuchs nodule, and the tissues become invaded by the lymphocytes and the epithelioid cells. Clinical feature. In the injured eye or the exciting eye, there is history of causative trauma. There is always iridocyclitis in the exciting eye, usually a plastic iridocyclitis which has been set up by the injury and has not subsided in the course of 3 to 4 weeks. Instead of quietening down, the ciliary injection remains. There is lacrimation and the eye is tender. Presence or absence of creatic precipitate on the back of the cornea. In the rarer cases of delayed sympathetic ophthalmitis, the exciting eye may have passed into the quiescent stage. The onset of sympathetic ophthalmitis in the second eye in such cases is then ushered in by the return of irritation, that is ciliary injection, tenderness, etc. in the shrunken globe. In the healthy eye, prodromal symptoms may occur in intermittent attacks, spread over a considerable period of time. The first sign may be the presence of keratic precipitates on the back of the cornea or the presence of retrolenticular flares and cells, which are noticed at this early stage because they are anticipated. On examination at this stage, there may be lacrimation, slight ciliary injection, tenderness of the eyeball, precipitates on the back of the cornea and vitreous opacities. Occasionally, there is some edema of the optic disc. When fully developed, all the signs and symptoms of granulomatous uveitis are present, varying in degree according to the severity of the case. There is usually vitritis, multiple yellow-white lesions in the peripheral fundus, Dallen-Fuchs nodules, and papillitis. Sympathetic ophthalmitis sometimes takes 2 or more years to run its course. Treatment: in every case of penetrating injury, with or without the retention of a foreign body, prophylactic and long-term treatment includes topical and systemic administration of steroids. The chief causes which prolong irritation are entanglement of the iris or ciliary body or lens capsule in the wound. Sympathetic ophthalmitis rarely occurs after excision of an injured eye unless it has already commenced at the time of operation. If the case is seen early, shortly after the onset of inflammation in the sympathizing eye, and if the injured or the exciting eye has no useful vision, this useless eye should be excised at once, as this definitely has a good effect upon the process in the sympathizing eye if performed early. At the earliest suggestion of inflammation, steroids should be given systemically in large doses. Intravitreous methylprednisolone 1 gram followed by 100 mg of prednisone orally tapered off slowly. This should be reinforced by topical use of dexamethasone 0.1% drops and topical cycloplegics. In all cases, 15 to 20 mg of prednisone should be continued for many months lest relapses follow its cessation, and the eye should be watched over a period of years. Daily doses of oral steroids are employed initially, but later it should be possible to change to alternate day steroid therapy. Steroid resistant cases or those with severe corticosteroid related side effects require immunosuppressive therapy. Oral cyclosporine A specifically affects T cell mediated immune inflammation and is useful in severe cases of sympathetic ophthalmitis as an adjunct to corticosteroids.